Welcome to Progenesis webinar, session 35. Today's topic is ICSI versus IVF, pros and cons. And we are very happy to have an excellent panel of lab directors. The presentation will start in a few minutes. We will have a 10-minute presentation for each one. Let me introduce our panel. We have with us Dr. Beyhan. He is the lab director at Fertility and IVF Center of Miami. And we have Dr. Anderson, and she is the lab director at Mainline Fertility Center. And we have Dr. Wiemer. He is the lab director at Poma Fertility Center. Thank you so much, guys, for joining us. So let's start with Zeki, if you would like to get started with your presentation. And after we finish all this presentation, we will have a round of discussion. And we will take some questions from the audience if anyone wanna go ahead and present and ask some questions. Thank you so much. Zeki, the floor is yours.
All right, Riley, how am I gonna just handle the slides? Are you gonna help me, or I'm gonna use them, or how are we gonna go about this?
I think you'll be able to click on the screen.
Mm-hmm.
Yep, it's working.
Okay, all right. Okay. So if I just click, we're gonna just proceed, right? Okay.
Correct.
All right, okay. All right, great, okay. First of all, I'd like to start by extending my thanks and appreciations to Nabil and his team for putting this seminar together. And in the past, and I'm really excited and honored to be a part of this conversation. Whenever I have a chance, I really enjoy it, and I find this very informative and valuable. Well, let's when it comes to today's topic, as you know, it's ICSI versus conventional IVF, and since I moved to human IVF practice for about 13 years ago or so, and started to attend our professional meetings around the same time, my observation was kind of interesting. In almost every single meeting I attended in those professional meetings, there had been a discussion of this topic, ICSI versus conventional IVF, and those debates actually most of the time is very passionate, with all for ICSI or all for conventional IVF type of titles and attitudes, and because of that, they all come with some sort of entertainment value added as well. In that sense, I mean, at the time, I was a bit fascinated by this perpetual nature of these debates. Actually, I was just basically moving to human IVF from academic background. It was kind of interesting for me too. But and after a while, when I look at when I took a closer look at the history of the human IVF field, and just have a better understanding of how things develop in the field, it became more obvious to me that there was a reason behind it, actually. So indeed, ICSI is one of the most, if not the most important assisted reproductive technology that is introduced in our field, and also just basically drastically changed the landscape in our field. In the last 2+ decades, I mean, since the first use in 1992, that was a huge evolution in that sense. And from the first days of this development, from the very first days of those to now until today, this discussion is always around, and it was always passionate, and people always put certain issues together when you're discussing these issues. In that sense, during that long period of time, is more than 2 decades of time, numerous studies has been conducted. People put their ideas up on the side of ICSI or conventional IVF. They look at the different infertility problems and under the perspective of ICSI versus conventional IVF or so. And this is, here we are after 20 something years, we're still having this discussion, but rightfully so, because of the reasons I mentioned, because every single day new information comes up, and we just have to look at those as science-based field anyway. What I'm going to do today is rather than just going through that entertaining type of all for ICSI, all for conventional IVF type of attitude, what I'm going to do today is basically I'm just going to give a very quick recap of where we are today. And I'm sure many of you are already available and familiar with the issues we're going to talk about. I just want to put that recap to put us in the common standing. And after that, I'm going to just basically move into what we do in our own practice and why we do it and what's the reasoning behind those, what's our justification of what we're doing. After that, I'm going to finish up with basically from my humble opinion, what I'm thinking about the pros and cons of the possible ICSI versus conventional IVF debate. And then after that, I'm going to just basically enjoy the contribution of my distinguished colleagues, and then go for the discussion. These are the most important part of this type of seminars, basically, to my understanding. Again, I'm going to start with a busy slide for the sake of time. I just try to concise the presentation in this way. As I mentioned, once we get the first ICSI usage in 1992 for the male factor infertility cases, that was a big revolutionary step in the field. With this technology, I mean, the couples who are experiencing male infertility cases were able to conceive their genetic offspring. And that just introduced a big factor in the field in terms of what we are able to do and help our patients. But from that time on, because of its phenomenal success in that setting, in the original setting, the reproductive biology field basically wanted to address a number of other infertility questions with the same tool. And they just look at the options of just basically applying to to other problems like unexplained fertility cases or complete fertility fertilization failure cases. Down the road, I mean, they extended all the way down to basically routine use of ICSI for unindicated cases as well. And if you look at this the graphs here, we are just as I mentioned, it's a kind of a busy slide, but in this slide on the left bottom side, we're looking at the use of ICSI throughout the years from 1995 through all the way down to 2019, if I'm correct. So as you can see here, we are starting from 20% usage of ICSI all the way up to 60-70% usage of ICSI as opposed to IVF, conventional IVF cases. This is coming from ICMAR database, so it is a worldwide, as a combination or compilation of the worldwide data. But this same trend basically is happening almost everywhere. If you look at the available data, we're going to see exact same trends in the United States. And also on the left bottom side, we see this is not a trend graph, but it shows the current graph in 2015. Again, depending on what in a continent we are looking at, or if you just split it down to the countries, you're going to see some differences. But at the end of the day, we see that ICSI usage is extremely, very prominently improved from the increased from the first days of application. And in the middle here, we're just looking at our CDC national summary data for 2016. Again, we are just dealing with the same type of issue here. We are looking at the typical age brackets, but as you see, when we are talking about male infertility cases, we're talking about more than 90% of the cases that go through ICSI. And even though the other case, non-male factor infertility cases, we are just talking about almost 70% of the cases are just handled by ICSI. This is a general trend in the United States, in the world, and almost everywhere. You see some individual differences from country to country, but this is the general trend. Let me explain the situation in our clinic right now. We are a all ICSI laboratory and clinic. Basically, almost every single patient comes to our clinic, just go through ICSI procedure. And it's almost, just once in a while, I should say, that we do conventional IVF. And why we are at this setting, and like many other clinics in the United States and other places as well, elsewhere as well, the main reason of the, why we do this is basically based on two premise. First of all, this could be open to discussion, but of course, when you are implementing a technique or a strategy in your lab, especially in our setting, there are two main questions we need to address. The one is efficacy, the other one is safety. As long as your analysis or your justification in terms of efficacy and safety meets your criteria, your threshold or whatever it is, then these technologies or these alternatives become a tool for you, and you use those. You use that tool depending on various other considerations. Based on the number of studies done so far, in the 20 years as indicated earlier, and there are a number of studies just conducted, and based on those studies, the ICSI versus conventional IVF debate in terms of efficacy comes to a point that as long as they are done properly, as long as they are conducted according to established protocols, so they are basically comparable. At least this is our judgment. They are comparable, if not better. Depending on the studies you're looking at, you're going to see in one case one is slightly better than the other, or the other way around. In terms of fertilization rates, blastocyst conversion rates, and main outcomes, the live birth and implantation rates. And when we consider those, we believe that, at least in our setting, we believe that these are comparable methodologies. The second leg of the discussion would be safety issue. And even though you have a technology that addresses your question and addresses your problems and provides solution to the issues you're dealing with, if the safety is a major concern, then it's again a no-go for you. But when we look at the safety issues as well, this is still a discussion where it's not finalized. But when we look at the earlier data when it comes to safety of the ICSI procedures, we see that we didn't see a major difference between ICSI and conventional IVF cases, especially when you use the correction for male fertility cases. In the earlier studies, there were a small increase in the ICSI usage and birth defects or so. But when it is corrected for the male factor involvement, they were just basically, it was not there anymore. Again, but this issue is are not settled completely, and there are a number of issues right now coming back, especially in the long-term health effects of this. Is still a discussion where is not settled, and jury's still out. But as far as we are concerned, the main reasoning, the safety and efficacy wise, ICSI was basically at a standing where basically similar, and safety issue was not indicated, at least in a definitive manner. That in that sense, when we were able to say that efficacy and safety wise, these ICSI procedure is a usable or is a valid tool in our setting, then at that point, it depends on, the use of this technology is depend on what you have, other factors in your system, and this is basically it becomes a part of the discussion, especially in my current clinic. PGT utilization is a very extensive. A big chunk of our patients or cases go through PGT utilization. And at the earlier days of PGT cases, genetic testing labs used to ask you to basically use ICSI as a precaution for contamination or so. Even though they are not asking this question directly at the moment, we see it as a extra caution in terms of your PGT results, and having those in line with the procedures. Another reason, of course, when you are looking at these issues, what you have in your setting, and is your setting is basically properly equipped to do and equipped to implement a use of a technology. In that sense, and when we look at our laboratory and staff competency, that basically we see that this is really is not a major factor for us to implement, and our system is just allowed to be done basically. And one of the criticisms again about using ICSI is also related to financial burden that could bring the patients. But again, this is not per se and unavoidable consequences, depending on your fee structure, and involvement of the insurance companies, insurance programs in the system. It may not be a major contributor. In our setting, basically, we come to a point that using ICSI as a strategy is not poses an extra financial burden for the patients. When we put all these together, mainly the safety and efficacy-wise, the comparability of these techniques basically allow us to address the issue with the other factors in calculation, basically. One more thing I would like to add here is that also the attitudes of patients and the culture of patient care in different countries. In the United States, you are all aware of that. Patient attitudes are also a factor in this type of decision-making processes. And compared to many other medical practices, our practice has a group of, has a full population of patients who come to the table with a number of, ideas. They just come with somehow informed, misinformed, or partially informed, whatever you put it, but they come to the table and just bring certain expectations with them. That's also a part of the conversation as well. As long as I'm underlining this, as long as you come to a point that efficacy and safety wise, these are comparable, then you should be able to basically address other questions and factor those in. Well, I'm going to go ahead and try to explain how we do this procedure, ICSI procedures, and then without getting into the details of the technique. As you can see, I mean, if you are just using all ICSI in your system, so basically you don't have to deal with a decision-making process, which is not a downside. I'm just mentioning just as a funny bullet point, basically. But anyway, I mean, when you're doing all ICSI type of treatment, so you're gonna just treat everything coming in the same way. So in our setting, we just basically inject our eggs on average 4 hours, 2 to 6 hours, depending on the cases. Injection happens roughly around 4 hours, and injections happens at HEPES buffer medium at 37 degrees Celsius. Sperm preps are mainly using microfluidic devices, as long as we have 1 million motile sperm in the ejaculate. We use those with the Zymote devices. And if it is less than that, and we just use alternative methods like serum up and simple wash type of techniques. And on average, we get 80-85% of fertilization rate with these type of treatment. And the rest of the outcomes are basically comparable to conventional IVF. As I mentioned, we don't have a side-by-side comparison in our setting, because we almost don't have any conventional IVF cases. But when we look at our data and compare them to the available data with similar practices and anything available in the literature, we see those are comparable, at least, if not better. Here I'm just giving a very simple data point here. We are here just looking at the fertilization rates. These are from last year's data summary from our clinic. As you see, the overall fertilization rates are 83.6%. This is based on per injected oocyte. And as you see, depending on the age and the quality of the eggs you're dealing with, that could vary quite a bit. Elasticity conversion rates, these are again overall ratios. It's almost 50%. As I mentioned, these are pretty comparable to data sets you're going to be able to see with the conventional IVF studies. As I meant, again, if not better, at least comparable outcomes comes out of these ICSI treatments. That's where we are, and that's why that's one of the reasons we are just basically sticking with this idea of all ICSI type of approach. Before going further, I just wanted to mention one point that Dr. Wiemer, both Sharon and Klaus made, basically, when it comes to fertilization rate comparison between conventional IVF and ICSI. That's absolutely, they are right on the point that when you are comparing fertilization rate based on per injected oocyte versus per collected oocyte, these are not comparing the same entities, like just comparing apple to apple. They're not apple to apple comparisons. But when I'd like to just underline that when you compare the ICSI and conventional IVF cases, just based on the injection or collected oocyte basis, again, you are having a disparity in your comparison, because when you just basically do ICSI, you just denude your oocytes. If they're mature, you inject them. The rest are not injected. But in conventional IVF cases, because you don't have any idea about the maturity process, you just inseminate them. But especially if you have some late maturation cases, you are just again creating an artificial environment where you are not comparing two similar entities. For instance, in those late maturing cases, you might be given your eggs to, basically complete the maturation down the process versus basically just taken out of them from the calculation. I mean, it's not a major point, but I just wanted to say that this is also not a good apple-to-apple comparison in that sense. And from my point of view, when it comes to the major advantages or disadvantages of the using ICSI in the system, I'd like to just basically give a couple of bullet points and then finish my presentation here. Again, I mean, when you use ICSI, apparently you're gonna be able to assess the maturation status of your oocytes, and I believe this is an important information to get an idea about your patient case, because I don't have the statistics here, but at one point we looked at the quality of the egg and maturation status of the cohorts from a single IVF cycle. They have a tendency to just repeat itself down the road in terms of quality and maturity rates. So if we consider this, having an assessment of the oocyte maturity at the time of insemination is going to give you an extra level of information. And again, I mean, this is not, it's not very critical, but low incidence of fertilization failure is always a positive thing to have on your side. It's not the driving factor to decide a treatment method, but if it is there, definitely it's going to be a helpful aspect of it. Again, because they have comparable main outcomes, that is again bring it down to the other factors, a clinic or physician or laboratorian basically just consider, and you can just use it as a tool considering other factors. Again, we are still using extensively PGT technology, and it is provide us with an extra layer of caution. As I mentioned before. But of course, on the other hand, I mean, you have to have a well-established laboratory and good lab setting to handle these without any problem, and that is a must, of course. The major issue from my personal point of view, the major issue, the only I would be concerned about this is the upcoming studies. Just recently, even there's a study just basically suggesting long-term safety issues. But again, when it comes to this type of meta-analysis type of studies, it is really hard to just come up with a very definitive answer. But this is a field based on science, and if the incoming data is going to be able to show us that in the long term, ICSI is just causing more damage than possible, advantages that brings with it. Of course, we need to sit down and just reconsider it. But I mean, at the end of the day, the safety is going to be basically going forward, going ahead of anything else. But as long as efficacy and safety-wise, if we can say that both technologies are comparable, then it has come down to the preference of physician, laboratory, and patient, and their decision on the care of that specific case. I think that just rests the question over there, to my understanding. Having said that, we are really looking at the upcoming data, incoming data. And if that data is going to tell us convincingly that there are other issues we need to consider, we need to sit down and consider as well. With this one, I'm just going to conclude my presentation, and I'm looking forward to the rest of the discussion. Thank you very much.
Thank you so much.
I apologize. Let me just mention one thing. If you don't, I mean, last year, ASRM committee on this issue has just put out a very nice report. I mean, it's a very nice review of the available data so far. And then just basically they addressed many of these issues we discussed here, step by step, and it's a very good review of the available data. And I think this should be something we should be just keeping as a reference. Thank you very much again.
Our next speaker, Sharon. Dr. Sharon is the IVF lab director at Mainline Fertility Center.
Okay, so I am clicking through my slides. There we go. So my name is Sharon Anderson. I'm from the Mainline Fertility in Bryn Mawr, Pennsylvania, which is near Philadelphia. Okay, I apologize for the delay. There's a little bit of a delay here. So I want to thank Progenesis for the invitation, and I am very, very honored to be a part of this amazing panel. So thank you very much for the invitation. So today's discussion is about IVF versus ICSI. Back in 1992, Dr. Palermo and others, when they introduced ICSI to the world and the United States, it basically revolutionized fertility treatment, allowing infertile men the ability to father children. So it's been around since around 1992. According to a recent, a study that was by Boulay out of JAMA, looking at the NAS statistics, back in 1996, about 76% of fresh cycles without male factor fertility were ICSI. And then by 2012, it increased to 93.3%. But what's really striking about these statistics is that with non-male factor fertility, it increased from 15.4 all the way up to 66, around 70%. And even today, we know there are a lot of centers that are doing almost 100% ICSI, even with the non-male factor infertility patients. So how do we perform IVF or ICSI in our lab at Mainline Fertility? So basically for IVF, we will, at first we will just cut the cumulus from the eggs. You can kind of see a picture here of them. You can see them with the naked eye. So we'll put about 6 to 8 oocytes in about 1 ml of fertilization medium. That's all under oil. And then around noon, we will add 150,000 washed motile sperm per group of oocytes. ICSI, it's, I'm sure everybody knows what ICSI is, but basically you're just injecting a single sperm into the egg. In terms of timing, and I actually emailed Dr. Palermo this week just to kind of see, how they're still doing things. But about 1 or 2 hours after the egg retrieval, that's when we will do the hyaluronidase or remove the cumulus cells away from the eggs. And then another 1 or 2 hours after the hyaluronidase, then we will actually do the ICSI. So there's a little bit, we give the egg a little bit of a rest between each step. At Mainline Fertility, we do about I did the statistics today, we do about 25% of our cases are ICSI, whereas about 75% of our cases are IVF. So we do mostly IVF. I'm sorry, yeah, mostly IVF. Okay. So what are the pros and cons of IVF versus ICSI? And I use this in discussing this with patients. The pros of IVF is that it's a little more natural, allowing sort of the strongest sperm to fertilize the eggs. Also, something that we don't usually talk about, at conferences is that it actually, we feel it gives the oocytes a little bit more time to continue to mature and for the sperm to fertilize. You know, maybe they'll fertilize in the late afternoon, maybe a little bit into the evening. The cons is that you always risk the chance of a low fertilization rate or even a failed fertilization if you don't do ICSI. And then of course with IVF, standard insemination, you'll see some 3 PNs, 4 PNs. I mean, true polyspermy when more than one sperm fertilizes that egg. The pros of ICSI, I mean, if you look at the statistics, especially, you know, well, obviously for male factor patients, you're going to see higher fertilization rates and a lower chance of the total fertilization failure. Although out there, it's reported that you still see about 1 to 2% total failed fertilization, even with ICSI. The cons, it is more expensive, obviously. There is more risk of the damage to the egg, and it is more invasive. It requires technical skill, more lab time, and also, you know, when you do the hiace, maybe around 11 or 12 o'clock, then you know, you sort of lock that egg in time, and you only will you only ICSI the mature eggs. So I got this, the idea for this slide from actually a postgraduate course at ASRM. And, you know, some people say, oh, well, ICSI has a higher fertilization rate. And the more important thing to keep in mind is to always keep in mind the denominator when you're calculating fertilization. So for standard IVF, we measure the number of 2 PNs. Right here, this is a 2 PN zygote here. So you measure, this is a fertilized egg. So it's the number of 2 PNs divided by the total number of eggs that were inseminated. And remember, when we're just inseminating the eggs that are surrounded by cumulus, we can't tell which ones are mature, which ones are very immature, which ones may even be atretic. You can't really tell 100%. So again, when we're doing IVF, fertilization rates, your denominator is the number of eggs inseminated. For ICSI, we only ICSI the eggs that are mature. And this is a picture of a mature egg showing a polar body right here. So after we use the hiace, remove all the cells, we can look at the eggs and we can tell which ones are the metaphase 2. So again, ICSI fertilization rates would be the number of 2 PNs divided by only the mature eggs. And this next slide, I actually did steal it from that postgraduate course that I saw. So I will give credit to whoever originally designed this slide. But again, minding the denominator, this is an interesting study by Lee in 2017. And it's an interesting study because it compares fertilization rate between IVF and ICSI in split insemination cycles. So half the eggs were ICSI, half the eggs were standard insemination. And again, we're looking at fertilization rates. And what you see here is if you just looked at these two numbers right here, it would look like the fertilization rate for ICSI is 72% versus 59% or 60% for standard insemination. But if you compare apples to apples, oranges to oranges, and you keep your denominator the same, meaning you're looking at your fertilization rate based on how many eggs were inseminated, you can see that the fertilization rate was actually higher in the standard insemination group compared to ICSI. So 59% versus 52%. So again, just looking at fertilization rate. The next slide, I also got this from the postgraduate course. This one is looking at just non-male factor infertility patients, okay? Not the men that really need it. So this is for other reasons. of doing the ICSI. And what you see, this is looking at the NAS data. So this is based on thousands and thousands of cases. And if you compare the conventional IVF outcomes versus the ICSI, you can see that the conventional IVF is showing, you know, better implantation rates, better clinical pregnancy rates, and better live birth rates. And again, I just want to stress that this is only ICSI in the non-male factor patients. So in mainline fertility, how do we decide on whether to use ICSI or not? And it basically boils down to it's patients with severe male factor, testicular epididymal sperm, and also if we see a morphology that's less than 4%, we'll generally recommend ICSI. Of course, previous failed fertilization. And interestingly, if we see a young couple with unexplained infertility, we may recommend to them, and they've been trying for several years and still not getting pregnant, we will recommend at least half ICSI, half IVF. We'll do a little bit of both. We do ICSI for PGTM or for monogenic diseases. Anytime we are thawing or warming oocytes, of course, you must do ICSI to achieve fertilization. So unlike other centers, we do not do ICSI for example, low egg yield. We don't do ICSI for advanced maternal age, and we don't do ICSI typically for poor egg quality, especially in those PCO patients that tend to have a lot of eggs and maybe not so good of egg quality. So this concludes my presentation. And again, thank you very much for the invitation.
Thank you so much for this great presentation, Sharon. Now we are going to the next speaker. I think we're gonna give Zeki a little bit more time, so we will go with Klaus. Klaus, are you there? We're gonna check the connection of Klaus. I think your mic is muted, Klaus.
There we go.
Perfect. Thank you so much. Thank you.
First of all, I want to thank Nabil and Progenesis for inviting me back to participate in these wonderful webinars. I just absolutely love doing these, and I'm really stoked to be with such an amazing group of scientists that I've known for many, many years. This is an awesome topic to discuss because when I first started in human IVF, ICSI was not available. So, okay, I'm trying to control my slide.
You should be able to just click the screen.
Yeah, there we go. Sorry. So it's so I'm going to just jump into this, what happened to sperm testing with the the presence of ICSI. And so I'm going to basically take that I think we've gone overboard a little bit with ICSI, and I'm hoping to be able to prove why. So really, if we think about what's the purpose of a semen analysis, the purpose of a semen analysis is to try to predict fertility potential in men. So really, these are simple questions, somewhat like an aha moment. Does a guy have sperm? Is the sperm alive? And is it possible from a semen analysis to tell if the sperm can fertilize the egg? Well, obviously, that has been a problem in the past because ICSI wouldn't have been developed. In my opinion, though, we had really started to develop some really nice advanced sperm testing functions. But then when ICSI came around, we pretty much just stopped doing advanced sperm testing. We started to do just a lot of very simple sperm analysis, sperm present, yes or no. And I think what that kind of also led to a trend was that the importance of how we prep the sperm was not given the same importance as it was in the past. So for example, centrifugation speeds, time of centrifugation, all these things kind of seem to go out the window with ICSI because we merely just needed a few hundred sperm to be able to do ICSI with, not really thinking about that how we prep those sperm as a whole could impact outcome. Okay, so we look about fertilization that happens, and so the slide here, the various numbers here, 1 through 5, these are what we think happens when an egg fertilizes, either in vivo or in vitro when we do conventional. The thing that I really want to point out is we still have no idea how the sperm that ultimately bind, have the acrosome reaction, and have the zone of penetration. We really don't know how that happens. So the problem that we face every day is that semen analysis don't really tell us. So if a sperm is going to measure, be able to do any of these functions. So on the left here, I've just listed some of the, or on the right here in red, I've listed some of the tests that we can currently do. And so the one I'm going to really emphasize is on the acrosome reaction assay, because this is an assay that I think was done a lot earlier, but now has lost a lot of favor. Why is the acrosome reaction such a great assay and a tool in our lab? Is that the acrosome reaction is required in order for an egg to be able to undergo the fertilization process. And so this diagram here from left to right shows you the acrosome being reacted and then slowly the material being removed. You can see the cap is exposed as the sperm is starting to enter the processes of the zona. And so, this test, so when you try to create a test like this in an artificial environment, we know by exposing the sperm to certain solutions, particularly follicular fluids, that over here on the right, using fluorescence microscopy with antibody testing, that we can see the sperm that react. We can see that the acrosomal cap is dark, and the sperm that don't react, you can see here that the sperm is really bright and fluoresces. In other words, that means that the acrosome did not stimulate and react. So this is a test that can be done often in an IVF lab. In fact, this is a test we do all the time to determine sperm test function, because we have found that the strict criteria morphology is nowhere near as important as the acrosome reaction. And this paper from Calvo et al. From 1994, so now many years ago, shows that the AR test and you can have values where you can cut off. So if you have an index score of up to about 4, we know that you're going to get lower fertilization rates. So the AR test really doesn't predict fertilization failures. It can rather predict who's going to have a lower or significantly reduced failure. You can see that once you get a percentage of sperm to react 5% and greater, that you can get really good fertilization rates. And so this is data from PAMA Fertility. So this is a little over 3,000 cycles. And really what I'm trying to show you here, that ICSI alone does not guarantee normal fertilization. What we did is we paired our data from 0 to 9% fertilization all the way up to 100% fertilization. And we looked at cases where the AR test is normal. And then we did this. And what was the incidence of, lower than 50% fertilization? Because we could think, I think as a group, we could say when we have less than 50% fertilization, regardless of method, something didn't work out. And you can see here in our clinic here that low fertilization rates occur evenly across all aspects, and that, fertilization rates are really, really high. So basically what I'm trying to say is that ICSI is not going to guarantee a normal fertilization rate in patients. And so I wanted to show you this data, and Sharon did a really nice job of touching on this for me in that, and she was discussing how IVF ICSI fertilization rates are determined. If we look at these fertilization rates here, we would see that ICSI looks like it has a higher fertilization rate. However, if we look at our IVF numbers, we also have to include in here germinal vesicle, M1s, immature eggs that are atretic, or completely degenerative eggs. You can see that these are different. The other thing that I wanted to show you is that we often use statistics wrong. If we just use a p-value here with such large numbers, we can see that ICSI is impacting the percent blastocyst and percent high quality blast. But if you use a Kramer's test, which helps solve for, or takes into account these larger numbers, we can also see that the impact is not as great. So I wanted to show this slide to show that let's be cautious about the statistics that we use. We tend to use these simple p-values and not adjust accordingly, in my opinion. So what we did next in our clinic was then recalculate the same data that I just showed you. And what we looked at was, what about if we try to correct? In other words, we looked at our IVF clinic and we saw our average maturation rates are 71%. And then we took our, so we took M1s based on, or M2s and looked at our fertilization rates. We actually see that ICSI fertilization rates are really no better than conventional insemination rates when we do the proper diagnostic testing. We can see that although statistically there's not a difference here, in my opinion, at least clinically, there is an impact of ICSI on blastocyst and blastocyst high quality. So then we wanted to dig into that a little bit more, and this is the last slide I'll be showing. And so what I wanted to do is, what's the effect of ICSI on blastocyst development? So the slide here on the left here, this is showing hypothetical data. So if we took 1,000 eggs and looked at fertilization rates, which we have in our clinic here, you can see that the rate of blastocyst development declines pretty steadily. But at the end of the day, we still have about equal numbers of blastocysts, whether we did ICSI or IVF. And that's including in this statistics here, the M1s, the germinal vesicles, all the degenerate material that we knew was never going to fertilize. But if we accounted for that, in other words, we adjusted for our M2s, we can actually see from the very get-go that we're getting more blastocysts doing IVF versus ICSI. And so really the paranoid thought that we often have is that we need to do ICSI in order to increase the number of blastocysts we have. I think this is kind of a misnomer. I think rather that if we did, better diagnostic testing, took into account better diagnostic tests, that I think we would find that our blastocyst development is actually probably going to be a little bit higher with conventional insemination versus ICSI, and that ICSI is not going to guarantee low FERT rates. So in conclusion, my final thoughts are, I believe that ICSI is overused today. Remember, male factor only accounts for about 35% of our cases today. Yet, so I believe that ICSI should only be used for true male factors and for true egg factor cases. And we still need to take into account what's the long-term impact of ICSI on children. A lot of these kids today are just 29, 30 years old. So they're adults now, they're just starting to have children of their own. So we don't really know what the consequences of that is. And then if we do the proper sperm testing, that we can really reduce the use of ICSI and allow more conventional insemination to occur. So those are really kind of my thoughts on that. And one last thing is that I think a lot of IVF labs would find that doing conventional insemination, you would actually have to step up the quality control that you do in your lab. You'd have to get better care of your oocytes. You'd have to do a better job of your sperm treatments. So in essence, it would force us to increase our game on the day of egg retrieval. And I think we could all use that. Thanks a lot, everybody.
My first thought when I looked at all the presentation is that, the majority or most of you agree that ICSI is not needed for every patient. And that, Klaus, you said maybe you should prioritize male factor for those cases. But however, when we see the usage of ICSI from the 90s all the way to 2020, we see that it's increasing, substantially increasing. Why do you guys think that people have that tendency of using more ICSI than needed? Klaus?
Well, that's a great question. Man, it could take like 30 minutes to answer that one. So I'll try to do it really quick. But I think before ICSI, when I worked in IVF labs, the male aspect, andrology, was often a separate discipline. It was a different lab often. You had andrologists who actually did andrology, sperm prep versus embryologists. So I remember I was working at Cornell when Dr. Palermo started working there. And in fact, that's who taught me how to do ICSI. And they have a complete andrology lab. We spent great efforts looking at diagnostics, looking at sperm integrity. In other words, we were trying to preserve the quality of the sperm, because often with male factors, we needed, even though there were few sperm, the sperm that we had, we needed to take care of. With the advent of ICSI, I think that you saw a change in a lot of labs. You didn't see a separation of andrology and embryology as much. You tended to see that sperm preparations became more of an afterthought. You didn't even do a lot of times mock sperm preps on these guys like we used to. You couple that along with the onset of embryo biopsy, and initially we thought we needed to do ICSI on all these conventional or on embryo biopsies. But the reality is we routinely biopsy embryos that have had conventional insemination and don't get contamination. In fact, Santiago Munet told me that you would have to literally put about 150 to 200 sperm into the biopsy tube in order for sperm to be the source of contamination for IVF. So that's one reason. And a lot of it is that, it is what it is, but I think a lot of physicians dictate how we're going to do fertilization. And the last thing that a doctor wants to do, and rightfully so, is sit across from a patient and say, we inseminated 10 eggs and none of them fertilized. I don't think doctors want to do that anymore. And I think that's probably why ICSI has been pushed so much, what was a very novel approach has been allowed to develop now into a culture. And now with embryology and everything kind of becoming more of a commodity instead of a science, and we don't think as much as we used to, we're more like now the lemmings follow the other lemmings and we just do ICSI because that's what everybody else does. Although there is some hope. Now with Zymote and things like that coming out, we actually did a trial with Zymote in the middle of writing a paper. You can get really good conventional sperm preps from Zymote with very little or no DNA fragmentation. So now you're starting to see the ship go the other way, in that now we go, hey, making a baby is a team sport. It takes two. And how we treat the sperm in a centrifuge, or how we treat the sperm period, is going to impact the percentage of embryos that become blastocysts. So I think the embryo biopsy push has really in some way kind of come back and said, hey, you know what? We get less embryos to biopsy when we have severe male factors. Why don't we try to do a better job prepping the sperm and see if we can get more blastocysts? And I think we're starting to see more of a change now.
Thank you so much. Sharon?
Well, I agree with Klaus in that I think a lot of physicians, especially the patients, they've invested so much time, so much money into fertility treatment that there's a lot of pressure to avoid that failed fertilization. So I think that's probably number one. I think PGTA is another one, but like Klaus, I just talked to Santiago Monet directly, and I still have that original email where he wrote back to me and said, no, ICSI is not necessary for PGTA. And they did do the studies, trying to see if there's any contamination in the sperm. He told me the exact same thing that he told Klaus. So I think PGTA. And I think a lot of people think that you get better fertilization rates. You see it all over the internet, and I see patients saying it to me, hey, I read that you get better fertilization rates. Why don't we just do ICSI? But, if you actually look at the correct denominator, you'll see that the FERT rates might be better with IVF. And also I agree with Klaus in that we have to be looking at things past fertilization rates. We have to be looking at usable blastocyst rates. and ultimately those the live birth rates.
Thank you so much. Zeki?
Nabil, my question is going to be, I mean, my answer is going to be kind of lame answer, and it's going to be extension of what the argument I given for why we do that. I mean, honestly speaking, I believe that this is a general statement in the field, especially in those clinics that use ICSI extensively. The idea that the ICSI and conventional IVF at the least are comparable, and then the safety concerns related to ICSI usage in the short and long term is not at least substantiated. I mean, that's the belief at least. Okay, once you make that efficacy and safety wise the equivalency argument, if you have that, then basically anything you're going to just basically get out of any of these technologies on the side of your treatment, or if you can provide anything positive on top of these two major components, is going to be a positive. This is again my belief, and I believe a number of physicians or a number of clinics that believe in the same premise, and that was the main reason that they keep doing it. But again, I mean, from a personal point of view, I don't have that, you know, all ICSI, all conventional IVF type of attitude at all. Especially depending on the incoming data, with more prominent data, this could be definitely, you know, addressed, revised, and should be revised depending on how it is. But the main reason that people keep doing this is that the equivalency between these two in terms of efficacy and safety, basically.
Very good. And we were, I think in one of your slides, you mentioned advanced maternal age. And I wanted to ask you guys whether, you know, patients with advanced maternal age do benefit or not from ICSI or from conventional IVF. Does it compute in your equation when you're handling an older patient? What way to go, Klaus?
We actually did some work in this several years ago, and the data showed that when you did, and we defined diminished ovarian reserve, these are patients that you give maximum amount of dosage of medications to, and you typically get, you know, 4 or 5 eggs, less than 10 eggs normally, like 5 or 6 normally. And in those cases, we found that ICSI did improve fertilization rates. So in other words, statistically, there were more embryos that you put into culture on day 1. But when you looked at either day 3 or day 5, there was no difference in the number of embryos available. And the reason why, with ICSI, you were forcing fertilization of eggs that never were meant to be fertilized. So even though statistically they had a 2PN on day 1, when you looked at them on day 2, they were still a 2PN. A lot of these embryos would arrest, not develop. So we pretty much have abandoned doing ICSI for, you know, diminished ovarian reserve or advanced maternal age or things like that. The only time we would ever use ICSI in these cases are if they've demonstrated at other IVF clinics that for whatever reason they get better fertilization with ICSI. And at that point, I would say we probably have some egg factor present that we still, you know, haven't developed an assay for, whether it's on the zona pellucida or the ability of the sperm to bind to the oolemma. I mean, who knows? Is that the egg or the sperm? It's like the chicken or the cart, you know, the egg. Yeah. You know, it's one of those things. So.
Thank you so much. Sharon, how do you handle your patients with diminished ovarian reserve as far as ICSI versus conventional?
So if you read, you know, the articles out there and what Zeki had just showed from ASRM, you know, it states that advanced maternal age really is not an indication for ICSI. And, you know, I also agree with Klaus. I think sometimes, you know, you get a cohort of oocytes from a patient and they're not all the same. Not all the eggs are the same. Some are good quality, some are poor quality. Sometimes ICSI just forces fertilization on an egg that never would have fertilized otherwise and probably shouldn't. And then therefore you see maybe a little bit higher of a fertilization rate, but when you look at usable blast rates or euquity rates or going out to live birth rates, it really doesn't improve outcomes in patients of advanced maternal age.
Thank you so much. Zeki?
Well, as I mentioned, in our setting, we don't have to make the decision in terms of we're going to use it conventional or ICSI, but I definitely agree with both Klaus and Sharon in terms of what's the outcome, or the ICSI is going to improve anything on that sense or so. Yeah. Because if we're dealing with the quality of the eggs, it's not going to change anything. Even though you get some fertilized eggs, if they're not good quality eggs at that point, then you're not going to get anything out. Basically, you are just delaying your uncomfortable call to the patients from day 1 to day 5 or day 6. Basically, I completely agree with that. With them in that sense. But again, I use ICSI on those patients. But if you don't have good eggs, then it's not going to change anything.
Very good. Klaus, you mentioned the AR test for acrosome reaction. How do you use it? Given you showed that lower score imply less fertilization. So when you look at that score, how do you adjust your conditions if you are using, for example, conventional IVF?
So that's a great question. So what we do is we have a diagnostic workup for all men, and it includes a complete semen analysis with a Kruger-Strick morphology. We do a 24-hour motility. We do also the hyaluron binding assay, the HbA, and then we do the acrosome reaction assay. And so with the acrosome reaction assay, we use a specialized culture media that has some follicular fluid in it. And what we do is expose the sperm to the fluid, for a short incubation time, and then we stain the sperm and we look at them on a fluorescent scope. So we come up with a score. And so basically it's the following. If you have an acrosome reaction score of 5 or greater, we do conventional insemination, assuming that you've got enough sperm to do that with. So that the sperm preps well enough, that the overnight motility and all that are you're good. So it's if you have an AR score of 4 or less, we do ICSI because we know that those sperm have a very low potential of having an acrosome reaction assay, despite the fact that they may have really, really good sperm, and great motility characteristics. Those are the cases where you get burned by doing IVF because you go, oh my God, there's millions of sperm, but none of them acrosomally react. So we use a score, 5 and over, conventional. If everything looks good, less than 4, they're ICSI no matter what.
Thank you so much. We just got the results from the poll. We asked the question, do you perform ICSI or conventional IVF? At what percentage? And 20% said 100% ICSI, 28% 90% ICSI, 14% 80%, and 23% 50% ICSI. So you can see how the rate of ICSI being used, if we just sum the numbers, I think we are in the 80% of people that use more than 50% ICSI. Then we asked the audience, what is your decision based on when you're choosing ICSI versus a conventional? And convenience, 16%. Then we have 57% based on rates, outcome, and 30% all the above. Only 3% said they use it for cost. And I think we're going to get into that cost factor because I know that there are certain clinics that would use conventional IVF to reduce costs on patients. We also asked, would you consider switching from ICSI to conventional if the outcome would improve? And 60% would say yes. And our question number 4, who makes the decisions when it comes to choosing ICSI versus conventional? 50% said physicians, and 32% said lab director, 42% said embryologist. And the last question is, what indication do you use for ICSI? and 60%, 62% said male factor, 55% selected previous failed fertilization cases, and 43% cryopreserved oocytes, 24% PGTA. So that's the stats that we got. I think most of it kind of match what we see in the presentation. What do you guys think about the poll? Klaus?
I think it's very accurate with what you're seeing out there. It's good to see, though, that the clinics are willing to do conventional insemination, because you've got companies like Zymote and things like that. You know, more companies now are talking about how to improve sperm preparations, how to decrease DNA fragmentation, how to harvest most motile sperm. These are great trends, because if we can get those into the marketplace so that sperm preparations become not as complicated as they need to be, then I think you'll see a trend of more people going to IVF.
That's great. So all three of you are using Zymotes, I think, right? According to the presentation. What is the benefit of using Zymotes to improve outcome? And I'll start with you, Sharon. And how does it work?
Oh, how does it work? So basically, the Zymote is a separation device. It kind of mimics, you know, the sperm swim up technique. I think it's very it's not invasive. You know, we're not centrifuging the sperm. We're not releasing free radicals that can have an impact on sperm function. So basically, the way it works is you add sperm to one side of the device. The sperm swim through the device to the other side, and then the sperm that swim through the membrane first are the ones that are collected, and they're used for standard insemination or for eggs.
Fantastic. And I did not ask you about your feedback on the poll. If you want to add something.
I think it accurately reflects what's going on out there. I do visit a lot of other centers, you know, throughout the country, and there are a lot of centers that are doing 100%.
Yeah. Yeah, and what surprised me a little bit, but not too much, that physicians are the main driver for ICSI, for choosing ICSI for those patients, 50%, according to the poll. Zeki?
Well, this is related to Zymote or
well, let's start with Zymote. I know that you have some clinical outcome with Zymote. Can you tell us a little bit about it?
Okay. As far as Zymote is concerned, I mean, in my current clinic and in the previous one, I mean, I involved in 2 small projects with the Zymote, and I had the chance to compare Zymote with this microfluidic device selection versus the traditional ones. They're like the density gradient separation or so, and definitely, I mean, the device basically improves the morphology and also DNA integrity. I mean, selects for the DNA integrity of the sperm. This is a small project I involved, and that's a pretty definitely we could say that. Does that you know translate into outcomes in the fertilization rate or other outcomes? I mean, last year we have a small abstract, again an abstract in the ASRM meeting, last ASRM meeting, where we just look at the basic simple laboratory outcomes and developmental outcomes of the you know eggs that are fertilized by Zymote treated sperm versus density gradient treated sperm, and we haven't seen a major difference in the fertilization, blastocyst conversion rates, or other pre-implantation development, you know, characteristics of the embryos. But because we use heavily used PGT cases. I mean, interesting. I don't know if it is related directly or not, but we have seen a small increase in the amount of normal euploid embryos in the Zymote case, treatment groups, basically. These are my observations. And because of that, we still keep using it, using the device. I mean, there's a small improvement in the fertility rates. It may or may not be related. It's not. It was not a strong, as a large population to give us that strength to make the decision. But there is some improvement, and that's why we keep using it. In terms of the quality of the sperm, I love it. And once you get these sperm out of these devices, they're really clean, nice. I mean, this is from a technical point of view, I should say. It's a very nice, clean, and samples to work with, basically.
Okay. Any impacts on pregnancy? Did you look at the pregnancy outcome in this context of sperm purification using devices, or just you employed?
No, we haven't done it. That's our plan, though. But I mean, because of the setting we have here and the way we use it, it is kind of difficult to do it because we don't have side by side comparisons. So we have to just compare those with different cohorts of embryos produced at different time points, and that requires more power to your statistical analysis, which we didn't have at the time, but we are looking into it.
Very good. I have a curiosity. When you guys are doing conventional IVF, you still strip the oocyte really hard. Is that required, or you don't, Klaus?
No.
You can tell us about that.
You just trim some of the cumulus cells off and leave those on. Actually, those are good to keep on. It protects the egg.
Yes, that was my point. So keeping the cumulus cells attached, that you would be more forgiving if it's a conventional IVF versus ICSI, correct?
Exactly.
And can you tell us a little bit about PGTA, since you guys have talked about PGTA? Can you elaborate a little bit why that is not a problem when it comes to PGTA, or is it a problem?
We've never had a problem with PGTA and conventional insemination. I mean, just from a mechanical perspective, there's sperm on the zona pellucida, and if you look at a spot and go, I think I want to biopsy the embryo here, but I see a few sperm, you can do one of two things: find a different spot on the embryo to biopsy, or many times you can just move those sperm off, detach them, and get them out of the drop. But I mean, we're much more worried about cumulus cells contamination than we are about sperm. It's just really a non-factor.
Yeah, we know that cumulus cells do contaminate sperm media.
Yeah.
So how do you handle that part when it comes to biopsy?
Well, what's easy is when you do conventional insemination, we usually clean the eggs enough to see if they're fertilized or not, because we're trying to reduce, any kind of mechanical cleaning of the eggs. Now, the sperm, thankfully, because of the hyaluronidase, the cumulus pretty much strip off. There may be a few cells on there, but what we do is by the time you get to day 5, day 6, those cells have typically just fallen off the embryo, or you can pipette them once or twice and they just fall off, because by then, they're no longer stuck to the junctions on the zona, and there's some atresia or they usually just fall off. Or they start to grow on the bottom. If you leave, say a half a dozen or so cells, you'll actually see them start to grow and become a monolayer. They attach that, and then you can just pluck them off that monolayer.
Very good. And I want to ask another question for you, Sharon, but if you want to add any points here, I would like to take it, and then I'll ask you my question. Would you like to comment? Yeah.
I think you kind of made a comment about like the mechanical disruption as you're removing the cumulus cells. You made a comment, Nabil, about that. And I want to reflect what Klaus said, in that, when we first, right after the retrieval, we only cut half of the cumulus off, and the egg is not even affected. And then if you do a standard insemination, the sperm bind to those cumulus cells, and there's hyaluronidase inside the acrosome of those sperm. So kind of naturally, the cumulus cells disperse. So it's a very, very gentle aspiration when you're removing the cumulus cells the next day to be able to see the PN. We don't really have any problem with, too many sperm attached to the zona affecting biopsy.
And so my next question is about the denominator. Does it matter, right? So one of the questions we got on the chat was, why not divide when you're calculating the conventional, insemination, fertilization with conventional IVF? Why not divide by M2s? Why divide by all?
Oh, that is a great question, because you can tell which eggs are mature and not mature. If you're doing ICSI on day 0, you can tell right before you do ICSI. But if you're doing standard insemination on day 0, you can't see. You don't know which ones are mature, which ones are immature. The problem is that the next morning, when you're looking for fertilization, there could be some eggs. We call it just popped a polar body, maybe like the hour or 2 before they were actually immature. When they didn't fertilize, but they look like they were mature. So, I think to compare apples to apples, oranges to oranges, I think it's best to look at your fertilization rates based on the total number of eggs that were retrieved.
Yes, and so if you divide by M2s, if you can, or if you divide by the all retrieved egg, wouldn't that make the conventional insemination with higher rates?
Yes. And I guess I was thinking about this. I guess, we can't really conclude that, IVF is better, but I guess we can conclude that there is not enough evidence to show that ICSI has better fertilization rates or outcomes in the non-male factor patient. ICSI is always going to be superior in the male factor patients, and that's what it was designed for.
Yeah. Any other comment from the panel? So what is the takeaway? You guys are the most experienced people in the IVF lab environments. What would you advise other peers, embryologists, when it comes to choosing ICSI for IVF and dealing with this? And I'll start with you, Klaus.
I would tell everybody that, try to get back to how fertilization occurs in vivo. Try to do conventional insemination, but you're going to have to develop some diagnostic tests along the way. You're probably going to have to improve your quality control processes, because a lot of times fertilization failures can be due to poor sperm preps or poor oocyte handling techniques. And those poor methodologies are masked by ICSI. So if you go into an IVF, if you want to improve your IVF success rates with conventional insemination, you really need to look at your day 0 quality control processes, and then also improve your sperm diagnostic test. I would consider looking at things like the Acrosome reaction assay, looking at the hyaluron binding assay, certainly do 24-hour motilities. These are certain assays that will all just help you become a better andrologist and also let you know how well things are going in your lab.
Thank you so much. Zeki?
Oh, I would go with the basic fact that let's look at the data. Data and science should be behind what we're doing. And as long as our convictions coming from the data out there, it is always going to be safe. And again, at this point, I am always just stuck with this equivalency of the 2 systems and go with that. But again, I'm underlying this: the data and science should be behind all our decision-making processes, basically. And for instance, sometimes we keep hearing that this is more. It should be data, not just some anthropomorphic, approaches we have sometimes. We just do this to all side that they just feel bad or something. That's not. If data tells you that when you do a certain thing to the eggs, and then it's better or worse, then we're going to go with that. I mean, I remember, for instance, as it goes back to, I come from a bovine background. Of course, we're not gonna get into species differences, but I created tens of thousands of bovine eggs when, for instance, put the eggs in a vortex machine and then just get rid of the the cumulus cell by vortexing them. I mean, Klaus, probably, I don't know if you used to do that, probably you would be familiar with this. And we used to vortex those and then create beautiful eggs, embryos, and calves out of them. So basically, we should look at the data rather than, certain things. And also sometimes I keep hearing that, okay, there's a more natural, fertilization. Again, I mean, there's nothing natural about IVF.
Very good.
I mean, nothing natural about what we are doing in terms of, putting a lot of hormones in the system, getting, zillions of eggs from a monoovulatory species. They're just taking biopsies, sending them. I mean, nothing basically natural about this. In that sense, I mean, I'm not arguing. I'm not saying that we shouldn't do it, but basically, whenever we do make a decision or something, it should be based on the data and science behind it. And as long as if we can say that this is acceptable or this is comparable to this, then we should basically based on those.
Very good. Very good. Thank you so much. Sharon, what's your takeaway message?
Yeah, I'm going to have a little bit of a different takeaway message. Back in the 90s, I was part of Klaus's and Palermo and Jack Cohen's courses. In fact, I think Klaus, you were actually one of the guys that taught me how to do ICSI a long time ago.
I think so.
Yeah. So, hey, ICSI is one of my favorite things. I love ICSI, but I do strongly believe that ICSI is art, technique. And my advice would be to you embryologists. It's not just a matter of just getting that sperm in the egg. There is a whole art to it. Gentle with the eggs to try to optimize. Don't only just look at your fertilization rates. Look at the quality of embryos that are coming from that cohort of ICSI eggs. Look at the usable blast rate, implantation rate. So, if you're going to opt to do ICSI, practice, and just always keep developing these ICSI skills.
Very good. We are coming to the end of the webinar. It has been really exciting to see your perspective on ICSI and conventional IVF. Very useful information. Next week, we will have a webinar on a case study of difficult IVF cases. And with this, I would like to give you guys a minute to introduce your practice and we wrap up the webinar. And I'll start with you, Klaus.
Yep, my name is Klaus Wiemer. I'm the lab director at Palma Fertility up here in Seattle, Washington. It's a welcome to be on these webinars. If any of the attendants would ever like to come and visit, we'd like to have you visit. We always have visitors visiting our labs. So come on up, as they say. Thank you.
Thank you so much. Sharon?
So hi, I'm Sharon Anderson. I'm the lab director at Mainline Fertility, which is located outside Philadelphia, Pennsylvania. We have the largest fertility center in Pennsylvania. We offer all aspects of fertility treatment. And we also have a very active clinical research department at our center. And yeah, that's about it.
Thank you so much. Zeki?
Zeki Beyhan. I'm the lab director of Fertility and IVF Center in Miami here. We are a small to mid-sized clinic with 3 physicians, and we are trying to help out the Southern Florida patients with their infertility problems. And again, if friends, colleagues, if you come down to Miami, our doors are open to, as Klaus mentioned, and we always have a good conversation with the colleagues at any given time.
Thank you
Thank
so
you.
much. Thank you so much. I would like to present my gratitude and appreciation for what you do for patients. It has been really fun to be with you during this webinar, and I will see you next week. Thank you so much and have a great day. Thank you.
Bye, everybody. Thanks for
Bye.
being here.
Bye-bye.
Bye.